Okay. Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alameen. Wassalatu wassalamu ala Rasulillah. I'm delighted to welcome you all today in the Ophthalmology Department Hospital Weekly Lecture, which will be a very important topic we face usually in ICU patients and sedated patients or other cases that they have poor eye closure. Dr. Nofal Juwaiser, our senior staff consultant from ophthalmology, she is an expertise on oculoplasty, and one of our colleagues who mostly deal with those cases. For many years, she will give us a talk highlighting about the condition in patients in ICU concerned about the eye care and eye complication and how to treat it. Please, Dr. Nauf, would you start?
Assalamu alaikum, good morning. Thank you, Dr. Sultan, for this introduction. Thank you so much all for joining me today to highlight a very important topic in the field of ophthalmology. The reason that I've chosen this topic is that because of the frequent amount of referrals we see in our department related to ocular negligence of patients in ICU. The aim of this lecture is to provide advice and information for clinical staff who are involved in eye care and ICU, and to prevent an eye complication that may occur. These three factors have to be addressed when the patient is admitted in the ICU department, such as protect first the eyes in vulnerable patients, identify disease that affect the eye in ICU patients, and treat them accordingly. The eye, as we know all, it's an important organ. It has to be kept in mind and to take care of it while the patient is admitted, not to ignore it and concentrate on the general health. It is as important as the well-being and well-being of this patient when he recovers and go back to his normal life. We don't want him to discover or surprise that his eye was gone. The healthy cornea depends on the ability to produce tear, able to blink and close the eye with rest or sleep. The sedated patients, usually this protective mechanism, the natural protective mechanism, is disturbed. The tear, it is an important substance that lubricates the eye, protect this, the globe, protect it, and protect the delicate membrane. It has a mechanical role in removing debris and dust particles. It distributes immune cells and antibodies, and it lubricates the eyelid for closure. Blinking and eye closure is also a protective mechanism, prevents the eye against trauma, distributes the tear and wash away any debris. Almost all patients in the ICU or sedated patients, anyone receive, those receiving muscle relaxant or having any neurological injury, ventilated patients, they are all prone to get this eye problem. The main problem affecting the front of the eye, which is the cornea, it is the window of the eye. It is a transparent part. It helps us to see the whole world and the environment surrounding us. We have to protect this part. The things that happen to the cornea, abrasion from direct injury to the cornea. Number two, exposure keratopathy. inability to close the lids for a prolonged period, it will lead to this exposure keratopathy from secondary to evaporation of the tear films, and so on. We can have also chemosis, which is conjunctival edema and swelling, infection of the cornea or the conjunctiva called microbial keratitis and microbial infections. Surface damage occur as high as 60% in those patients. Thus, applying a clear protocol for prevention and management will prevent the majority of corneal problems. So we need to protect the eyes of those vulnerable patients. First, assess the eye and those patients at the onset of the care plan, then throughout the patient stay. Here are pictures showing the degree of lid inability to close the lids. It's called lagophthalmos. We assess it by grading the degree of the closure. So as to say, grade 0 will be complete lid closure. The picture in the first left, top left picture, it is complete lid closure, so the patient here is safe. Grade 1, there will be slight conjunctival exposure, and grade 2, where there will be corneal exposure as well, lower half. So the protective measure in these cases to be taken is taping, lubricating the eye, or using moist chamber, and in severe cases, a closure of part of the lids, which is called tear therapy. We have temporary or permanent tear therapy. And grade 1, usually lubricant and taping will be enough. And if it is severe, then we can do suturing with lubrication. Eyelid first need to be bathed with warm water. We have to clean the eyelids, clean any debris, then insert the ointment, the lubricant, as we see here in the picture on the left side. They pull the lower lid and insert the ointment between the lids and the conjunctiva. Then we close the lid with tape, ensuring there is no malposition of lashes. The studies have been shown that have been made to compare the efficacy of using combination of ocular lubricants and securing tape over the eyelids with the use of swimming goggles to prevent corneal epithelial breakdown in sedated and semi-conscious intensive care adult patients. Here, in this picture, the top bottom shows how to apply the tape horizontally over the lids, ensuring tight closure of the lids. In microbial keratitis, it is a severe complication of corneal exposure. A variety of eye care protocols are being used to prevent exposure keratopathy in the ICU patient and ICU patient, and there is no clear consensus defining the most effective for protection. So they were carrying on doing some kind of studies to compare which method protects the eyes effectively. This is one study. They did it among patients in the ICU. Prospective comparative trial. Compare the efficacy of using combination of ocular lubricants and placing a tape. They call it open chamber method. And the second picture, they create a moisture chamber by using swimming goggles and moistening the eyelids with gauze soaked in sterile water for 12 hours. They call it the closed chamber. They want to see the efficacy of preventing corneal epithelial breakdown in the ICU patients. From this study, they found that using a closed chamber method offers better protection against exposure keratopathy as compared to the open chamber method. But each study have its disadvantages and advantages. I will explain it in the coming few slides. Okay, here all patients with a Glasgow Coma Scale score of less than 10/15 admitted over 4-month period to the ICU were included in the study. All patients were examined by ophthalmologists within 24 hours of admission and subsequently every day until the patient completed the study. The patient will be declared completed the study if they recognized any improvement in the eye opening, or he's discharged or developed corneal lesions or passed away. Detailed eye examination was carried out to assess the eyelid position, pupillary reaction, conjunctiva, and corneal changes. In this table, they put a few points, to assess the efficacy and the effects of this study, such as the eyelid position here. They grade it into 5 areas, like conjunctiva, if there is only conjunctival exposure, if there is the lower quarter of the cornea exposed, if there is, or if it is fully exposed. And then also they address the conjunctival edema, which is called chemosis, if it is absent, present, or it is associated with Bellin. Corneal changes, if there is only erosions and punctate epithelial erosions, and which part of the cornea is involved. Is it the whole cornea, part of it, or the only inferior third? They studied 122 eye patients in randomized open chamber group and 126 eye in the closed chamber group. They found incomplete lid closure was noticed in 74 of the whole group, like sort of to say 30% had exposure keratopathy of these groups, even with these measures. 27, which is 21%, had exposure keratopathy. 81% had bilateral lesions, and this is quite a large amount. And the open chamber group also, they are the most patients who had this complication more than the closed chamber group. And in this table also we see the extent of ocular surface exposure. Like if there is no corneal or conjunctival exposure, it occurs in 88 patients. Here also the extent of exposure keratopathy in open and closed chamber group. So they calculated all of these measures, and they found that most corneal abrasion developed within 48 hours of admission. 37 of the, like 95%, occurred in open chamber and 80% in the closed chamber. The exposure keratopathy were more severe in the open group. Grade 1 conjunctival edema noted in 22% in the open chamber and 28% in the closed chamber. Other complication observed, such as lid abrasion and conjunctival abrasion, occurs in 12% in the open chamber and 6% in the closed chamber. It was found that incomplete lid closure and use of muscle relaxants were associated with corneal disease. Like here in group 1, those with the open chamber using taping and lubrication, they had more corneal exposure. Whereas in those group who used the goggles causing pressure and caused edema to the group, and they developed conjunctival chemosis. All of the 34 eyes with incomplete lid closure at admission in open chamber developed exposure keratopathy, while only 40 eyes in closed chamber showed the same, which is less. In discussion here, in healthy individuals, the ocular surface is protected by natural defect mechanisms such as bactericidal effect of the tear itself, film, blinking, and adequate lid closure. And this mechanism is lost in our sedated patients. Tear film, as we know, contains antimicrobial substances such as immunoglobulin, lysozyme, ceruloplasmin, lactoferrin, and complement components. Use of muscle relaxant sedations, patients on ventilation contribute to inadequate lid closure by decreasing the tonic contraction of ocular muscle. In this study, it showed that 32% of 122 eyes developed exposure keratopathy with the use of lubricants and tape, while 88% out of 126 patients had the same with the closed chamber. Here, conjunctival edema occurred in 22% in eyes in open chamber and 28% in the closed chamber. And the abrasion also occurred more in the open chamber while the tape is being removed. Pressure of the goggles caused lid edema. 34 eyes developed corneal disease in open chamber, while only 11 of 40 eyes developed the same in the closed chamber. So the chamber method reduces the incidence of corneal keratopathy to 8% compared to 32% with open chamber group. We want to identify the diseases of the eye. First, we have to see incomplete lid closure and decreased blinking, which leads to evaporation and uneven distribution, which will manifest as red eye. This usually affects 20 to 40% of ICU patients and 60% of sedated patients, which is quite high number. And prolonged epithelial defect, this will lead to scarring of the cornea, eventually perforation and infection. Chemosis also happen which is swelling of the lids, if the lids are unable to close completely, or lid will not be closed because of the chemosis itself. The risk factors here: compromised venous return from the ocular structure, which is positive pressure, ventilation, or tight endotracheal tube taping. Edema, which happen in hypoalbuminemic patients. Gravitational causes increases the hydrostatic pressure in prone ventilated patients. Want to have also addressed the importance of checking the eye of those prone patients. Increased capillary leak and systemic inflammation, and then also microbial infection. The eye become colonized with bacteria in the ICU. 77% of ventilated patients develop this infection within a week to 6 weeks. 40% of prolonged ventilation and sedated patients, they will also develop this kind of infection. And the most common isolated organism from the ICU were found to be such as Pseudomonas aeruginosa, Actinobacter species, Staph epidermidis, the respiratory secretions. It is a major source of ocular surface infection with aerosols from tracheal suctioning and direct contact from suction catheter. Conjunctivitis, it is defined as sticky red eye. It is usually bactericidal, highly contagious. It might infect other patients and the health staff as well. Here in this picture, we can see examples of these. Here, the first picture on the top left shows a sticky lashes with discharge on the lashes. The eye is red, kind of red, but it's not showing here clearly. The second slide, there is no discharge, but the eye looks red, and this is also an alarming sign. So in management, when you see such cases, you have to take a certain action, like take a conjunctival swab first, then clean the eye and apply the antibiotic ointment. If you noticed dullness of the cornea or haziness or white spots, you have to call the specialist. Microbial keratitis, affected by exposure keratopathy. It is vulnerable to bacterial invasion and can result in deeper infection leading to permanent damage and loss of vision. And this is called corneal ulcer, which is an epithelial defect on top of underlying white-gray yellowish opacity. We can see it here in the first slide on the top left. This is a kind of corneal ulcer, which is a serious condition and have to be taken seriously and to be treated right away. Next slide, it's unfortunately I cannot show it. I cannot zoom on this picture. It shows, you can see it's like a dendritic. This is called dendritic ulcer. It happens in patients with herpes. It's like a tree kind of projecting epithelial defect. It can be detected by applying fluorescein or rose bengal dye. Rare condition also to be addressed in the ICU, like red eye in septic patient may indicate endogenous endophthalmitis caused by spread of infection in the bloodstream to the eye. Recurrent hypotension can cause also blindness from ischemic optic neuropathy, and ventilated prone patients increase intraocular pressure with periocular swelling can decrease the ocular perfusion pressure leading to ischemic optic neuropathy, central retinal artery occlusion, and visual loss. Prone-lying patients also can develop acute glaucoma and visual loss because of the edema and the thing we explained earlier. The cornea will be cloudy and pupil will be fixed, dilated. This slide's showing a small lens. It happened in most common tertiary hospital here, unfortunately, with an elderly patient who underwent spinal surgery. He was bedridden in the ICU for months without taking care of his eye. He was having a corneal exposure with lid incomplete lid closed for a prolonged period. He developed corneal perforation. No one was aware of that. Unless they found something popping out from his eye, they called the ophthalmologist and say, please come and see this patient who had this incident, like something coming from his eye, and we don't know what is it. And it's the doctor found out to be this is the lens of the patient himself popped out because of the perforated cornea. So we don't want our patients to reach to this extent, and then we can't save the eye anymore. So the treatment for this kind of patients, like if we prescribe any kind of prescriptions, lubricant for the tear lubricants or ointment, we should first address the drops. We have to give the drops before the ointments, and if there are more than one drops, we have to wait 5 minutes between each drops. When putting in the ointment in the pore lid closure manually, we have to shut the eyelids to ensure spread of the medicine. If there is systemic or suspecting a systemic fungal infection, then antifungal treatment should be given. For those with Candida albicans, use fluconazole. If it is Aspergillus or non-Candida, fluconazole would be a good choice. And this is also another examples of our patients in the hospital being referred to us with this kind of exposure keratopathy. So the take-home message, or in conclusion, I hope I gave you some valuable points to improve your understanding and taking better care of the ocular health of your patients. And the take-home message, always check the eyelids, the closure, check if the eyelid is closed properly, check for any redness, for any discharge, or if there is any white spot on the cornea or dullness, any edema, you have to inform the specialist. Keep always the eye lubricated, and if there is incomplete lid closure, please ensure that you apply tape on the lids. Thank you very much.
Thank you, Dr. No, for this great presentation of the patterns and complications, treatment of eye complications in ICU patients or sedated patients. I would like to open the floor for any questions or comment. Please, if you could write down in the chat your questions, so we'll answer it. By the way, you will get an evaluation link for the lecture by the time you leave this presentation. Kindly fill up the form, so we'll review it and see how the lecture and the benefit of it. Dr. Nof, if you would recommend anything at presenting patient to the ICU, or let us say any patients who's presenting with low Glasgow Coma scale. So most of the time, those patients are really very sick. Doctors will always concentrate on the general situation of the patients, inotropes, building up the circulation, recovering the patients from, for example, critical illness. What would be the hints or the measures that we would take to prevent those complications?
Yes, thank you, Dr. Sultan, for your question. This is an important question. So as soon as the patient come to us in the ICU, health provider, nurses, practitioner, they should be aware of his lids, the status of his eye condition, especially if he's if he's comatose, ventilated or sedated. This will affect, as we said, the closure of the lids. It will affect the contraction of the orbicularis muscle, which is a muscle around the eyelids to help closing the lids. They have to start applying lubricant. We prefer preservative-free because he will be long, especially if he's a long stay patient. We have to put ointment like 2 times or 3 times according to his condition. If there is any exposure, leg of thalamus, then we start to apply the tape. And if there is anything that, like we explained, redness, discharge, dullness of the cornea, they have to inform the ophthalmologist.
Thank you, Dr. We got a couple of questions. Dr. Zaheri has a question: which patients should have the tarsorrhaphy?
Tarsorrhaphy, this is the ophthalmologist. He will decide if he saw the patients in long stay and they don't expect the patient to recover soon. His eyes completely opened all the time, and they found some starting to, if the patient developed some kind of corneal exposure, discharge or redness or some thinning of the cornea, then they will refer him for the suturing. And there are 2 types of tarsorrhaphy, complete, permanent, or temporary. The permanent one will be suturing of the ends of the 2/3 of the lids, the outer third of the eyelids, whereas the temporary, it will be placing suture temporary in the center of the lids. It will stay for 2 weeks, the temporary one, whereas the permanent will be lifelong.
Another question from Dr. Amal. Can we use local antibiotic prophylactically as prophylactic?
I don't prefer using antibiotic if the patient doesn't have any predisposing factor. But the environment of the ICU, as we know, it's already colonized with lots of with bacteria. But to do this protective measure, it will prevent them from having infection.
One more question. How often should we apply lubricant eye drops?
Usually, if the patient is stable, I would recommend like 4 to 6 times drops, and the ointments like QHS.
All right. Do you have any other questions or comment? All right. I might probably highlight one point that Dr. Nof stressed already on by the end of this lecture. As we know, human body has many protective mechanisms for each organ. Could be like initiated by a trigger, or it is like, autonomic. The eye has the blinking effect that usually lubricate the eye, keep the eye surface moist. And one of the most important things that we lose at the time of getting loss of consciousness or decreased consciousness or even trauma, is that we lose the usual luster and glistening of the eye surface, which is very, very early indicator of good lubrication of the eye. So in those patients, I know by protocol, and usually most of the ICUs all over the world, they have protocol for lubricating the eye. There is difference in applying the protocol and referring the patient's indications, but most common agreement is on stress on lubrication in every patient with reduced Glasgow Coma Scale or reduced consciousness, and to refer any patient who has either discharges or redness on the eye to the ophthalmology. So mostly of the time, if we follow these protocols and we keep an eye, yes, the patient is very sick, but there is an organ that could be very, very virulent to either organisms or to loss of the physiological protective mechanism like blinking or eyelid closure. Usually we need to keep in mind that the eye of the patients should be checked and referred adequately when it's really needed. Do you have any other questions? No. I think we concluded our lecture today. I would like to thank you all for your time and your participation in the lecture. Thank you, Dr. No, for this valid informations and review of the eye care in ICU. It was really very informative. Thank you all. Assalamu alaikum wa rahmatullah.
Thank you.